and the presence of cardiovascular disease is a particularly problematic situation. But in contrast to the adult practice, 80% of the children undergo kidney transplant because, as we'll show you in a moment, the quality of life is markedly improved compared to undergoing chronic dialysis. The diagnosis of chronic renal disease or developing chronic renal disease follows the RIFLE criteria, which is risk, injury, failure, loss, and end-stage kidney disease. And they are basically reflect increasing creatinine and decreasing GFR, glomerular filtration rate. And predominantly the lower two are the biggest problems, where we have markedly reduced GFR in the neighborhood of under 30 mils per minute per square surface area. So groups 4 and 5 at the bottom of this slide really represent the children in whom the clinical manifestations of chronic renal disease are most germane to our practice. And as I mentioned, the epidemiology varies around the world. The highest incidence, and these are per million patients based on population. That's what PMARP means on this vertical axis. New Zealand, the UK, and the USA are the highest incidence, between 16 and 20 per million patients. And it goes down from there at the far end, the lowest incidence being in Russia, Finland, Japan. And that depends, of course, we're depending on the local canvassing and surveys. There are many countries in whom the data is pretty sketchy, so we're not completely sure that the incidences are accurate, but we do know that certainly in the developing countries and the developed countries that we have a pretty good handle on those who need the care in chronic renal disease. This is a multifactorial problem that affecting many organs, although it begins with a kidney, but we see here in the child on the left versus the adult on the right, the physiologic or pathophysiologic manifestations are prominent in terms of hematologic signs, that is chronic anemia, hypertension, the heart disease, and those are two serious problems that we try and address in the child. In the adult, we see cardiac disease being the predominant factor that is associated with poor life expectancy and sudden death, with myocardial infarction, amongst other things, occurring in these patients. So how do we address the child who has chronic kidney disease? Well, we begin by looking at some broad stroke management issues. There's metabolic arrangements, and that is something with which we are quite familiar. In terms of fluid and electrolytes, because the patient basically has a filter system that is incapable of dealing with extremes of concentrated or dilute electrolytes or fluid overload or dehydration. So sodium is often restricted in the spectrum of the kidney's ability to concentrate or dilute urine, and as a result, we have to be very careful on their diet, on what they can take in and what they can't. As the GFR decreases, their ability to manage a range of sodium loads diminishes. Same with the water. They can easily develop congestive heart failure, become water overloaded, and so we certainly have to be careful with the operating room not giving them excess fluid. But potassium is probably the biggest problem because of its arrhythmogenicity, and they have no alternate means of controlling the potassium, and should their potassium load increase, or the level increases, particularly with a GFR that falls below 10%, as recently happened to a brother-in-law of mine with diabetic end-stage renal disease, having a cardiac arrest from hyperkalemia. So there are exogenous sources of potassium that need to be controlled in diet, or intracellular, in vivo sources of potassium that may occur with rhabdomyolysis or other diseases that are coincidental with the kidney disease. And these are, of course, acutely treated by stabilizing the myocardium with calcium or K-exolate to remove the potassium from the body. And then the last is a chronic metabolic acidosis, that together many of these are addressed by one form or another of dialysis. The two other problems that aren't as easily treated, certainly not by dialysis, are the hematologic findings and the cardiovascular findings. In terms of hematologic findings, the chronic anemia is quite devastating, certainly for a child who would like to be active. It zaps their energy, and they really do not want to participate in much. And so the issue has been brought forward that EPO, one of the major mechanisms by which chronic renal disease diminishes the hemoglobin, can be supplemented with exogenous sources, and that certainly improves the quality of life, as I'll show you in a moment. In terms of using regional blocks, and we had a beautiful session this morning about regional blocks in patients, we have this difficulty in assessing their level of coagulopathy that may be purely due to platelet qualitative dysfunction, not quantitative. And so putting regional blocks in uremic patients is not something that we take lightly. We do take a pause on that. In terms of the cardiovascular manifestations, in adults it's a rampant problem associated with coronary disease and left ventricular hypertrophy. In children, it's a difficulty in controlling the hypertension, and as we said earlier, it may be a major cause of death. And one of the mechanisms, of course, is to restrict the fluid administration and prevent volume overload. So in terms of the anemia, in terms of ensuring that the child remains active and has a good quality of life, there have been a number of strategies adopted to try and bring their hemoglobin back up to normal, keep it from falling below the magic level of 10. Here are the causes of anemia in a patient with chronic renal disease, but the administration of serial erythropoietin subcutaneously over a period of weeks, preceded by iron and folic acid to prevent microcytic anemia, and of course vitamin C, which helps the absorption of and the activity of erythromycin, are added to the regimen. And as a result, at least in this adult study, we can see that the quality of life, which is above the horizontal line shown here as 0, versus well, oh, maybe we'll get this mouse on here. Yes. So here's our horizontal 0 point, and all the lines that are in blue are above, and oh, thank you. And those are patients whose hemoglobins were restored to about 14 or 15 grams % with EPO, but those who had a hemoglobin that fell below the level of about 11, you can see there was a decrement in the quality of life, whether it's physiologic function, physical activity, socializing, and mental health. And so in this study, they couldn't use a placebo comparing erythropoietin. They compared a full dose of erythropoietin with a partial dose. And so even those who got a partial dose of erythropoietin had a reduced quality of life. So it's imperative that we ensure that our children are optimized in terms of their hemoglobin before they come to surgery, not only to minimize the risk, a need for blood transfusions, but also to ensure that their recovery can be managed well and the child does well. And the bleeding diathesis, the risks associated with chronic renal disease relate to this qualitative platelet dysfunction that is very difficult to quantify. Some have used DDAVP in perioperative period for these children to minimize bleeding from major surgery, and others have gone to cryoprecipitate and even estrogens in some reports, all to try and attenuate the bleeding problems that may occur in the perioperative period. In the preoperative assessment of the child who has end-stage or chronic renal disease who is undergoing intermittent dialysis, it's important to document when the child last was dialyzed. Usually it may be Monday, Wednesday, and Friday, so if the surgery is planned, hopefully it's on Tuesday or Thursday, not the day of their dialysis, because it would have been 2 days since they were last dialyzed. And we need to document how much weight was removed and what their current dry weight is, and then the post-dialysis electrolytes, which may not be a routine test that is ordered if the child is just undergoing weekly dialysis. But preoperatively, we do want to know how the potassium has been managed. And lastly, it's important, of course, depending on the severity of the surgery that's involved in the fluid shifts, whether or not the child makes urine, because we would want to document and collect the urine, but the child may have no urine output whatsoever, which makes that a moot point. So preoperatively, these are important aspects to document. In terms of the hematology, we have already spoken about the need to document a CBC, and make sure the hemoglobin is adequate, and whether or not there are any other extraneous hematologic and coagulopathic contributions. And then lastly, it's crucial to have assessment of the cardiovascular function. Depending on the severity of the disease, how long the child's been in end-stage renal disease, an echocardiogram may be warranted to document compromised myocardial function, presence of pericardial effusions, because congestive heart failure is associated with 10 to 20 times the cause of death. And so that child needs to be optimized if on examination preoperatively we detect RALs and evidence of fluid overload, the weight hasn't been reduced, the child has been consuming too much water, because we could run into trouble certainly with induction of anesthesia. How long should the child be fasted? Well, no one has really investigated this aspect thoroughly, except to suggest that a patient with end-stage renal disease should be fasted at least a normal duration. Now, if it is a source of the renal failure is due to diabetes, it's possible that the patient has a gastric paresis and delayed gastric emptying in that respect. But if the child doesn't have that, the question is, well, 8 hours is good, but is 6 hours almost as good? And so this group looked at echocardiography, echo of the gastric antrum to determine whether or not there's any fluid and food in the stomach after an 8-hour fast. And after the meal, they found large volumes. Renal failure, slightly larger than in control. 6 hours after the meal, there was still substantial volume in the renal failure patients than in control. And so this Perlis grade, which is a measure of how much liquid or food, or that there is liquid or food in the gastric antrum by ultrasound, documented that while none of the patients who had normal renal function, who had eaten a meal 6 hours earlier, had any evidence of food substances in their stomach, there was a significant number of those with renal failure, 16.7%, who had evidence of liquid or solid in their stomach 6 hours after their routine meal. So it is important to at least follow the guidelines for fasting in patients who have renal failure, not try and short circuit, like have an anesthetic begin even 6 hours afterwards, because you may be unexpectedly dealing with a patient with a full stomach. So how much fluid do we give these patients? You know, the father bear wants too much, and the mother bear says not too little. The little kid and the little bear in the middle says, I want just the right amount. And the bottom line is that's exactly what we should be doing. This is probably a very challenging fluid balance situation, not unlike a newborn. And so we have to be very judicious to avoid both volume overload and sodium overload in resuscitating the patient during surgery, which means careful measurement of blood loss and potential fluid shifts during the surgery. Don't let the IVs run away with you and pour in excess amount of salt and fluid, because the patient cannot excrete them out in many cases. What about the choice of fluids? We've all been taught that normal saline should be used because it contains no potassium. Lactated ringers avoided because it has 5 or so milliequivalents per liter of potassium. But in fact, in this study, in anesthesia and analgesia in patients who are undergoing kidney transplant, the evidence showed that the peak potassium level, and on the basis of non-anion gap acidosis, was substantially greater in the normal saline group than in the lactated ringers group. In fact, 0% of the lactated ringers patients had a potassium greater than 6, but 20% of those given normal saline. And the reason is the acidosis causes a shift of potassium and raises it. It is transient because it decreases by the end of surgery as it all settles down, but if you're infusing fluid rapidly, do not infuse large volumes of normal saline. Which inhalational agent should we use? Well, studies with desflurane, isoflurane, and sevoflurane have not really shown to be problematic in these patients. The in vivo and in vitro metabolites really don't cause a problem. A, desflurane isn't metabolized, and B, sevoflurane does not cause further nephrotoxicity if the patient isn't completely anuric and without renal function. But similarly, compound A has really not been shown to be a problem, although if you prefer, you can use a an absorbent that has no potassium hydroxide and no sodium hydroxide. No evidence in humans. Now, what about the drug use in children with chronic kidney disease? Well, there is a dearth of data that describes how the pharmacokinetics of anesthetics, IV anesthetics, differ in children with chronic renal disease compared to normal renal function. Now, the mechanisms for possible altered pharmacokinetics really fall into three categories: changes in the volume of distribution, changes in the metabolism, or changes in the elimination. In terms of the distribution, of course, hydrophilic agents are distributed in more water, and there's lower albumin concentration. In terms of decrease in metabolism, the metabolism is decreased, and this is primarily on the basis of uremic toxins that interfere with both cytochrome P450 expression and P-glycoprotein transporters that keep compounds out of the body. And finally, elimination, obviously, any conjugated agents that are renally excreted would not be excreted as well with no perfusion of the kidney. So, what about specific agents? Well, the non-depolarizing agents basically are metabolized in the liver, but the metabolites are renally excreted. So we're going to look at what happens to rocuronium in a minute. But the isoquinolinoniums, like mivacurium, cisatracurium, undergo spontaneous Hoffman degradation, and we really don't have to worry too much about those, except that the esterases may be impaired because of uremia and chronic renal disease. So here's some evidence looking at rocuronium kinetics in adults, and you can see there's about a 25% increase in the elimination half-life of rocuronium in renal failure compared to normal renal function. So the dose to paralyze the patient is the same, but the repeat dose should only be given once a neuromuscular twitch monitor shows that you're beginning to recover, and that you can expect to take about 25% longer than otherwise. Sugammadex, it's same thing, and you can see in patients who have, looking at the rocuronium elimination versus the sugammadex, that actually the rocuronium effect, the elimination half-life is only doubled in chronic disease, but sugammadex, the elimination half-life is increased by about 20-fold, markedly greater. Finally, succinylcholine. Succinylcholine does not cause more hyperkalemia and renal failure unless it's associated with a neuropathy. Opioids, a comment about opioids, both morphine and Demerol metabolites accumulate in patients with renal failure, and they're somewhat unknown. We can't really fall carefully onto the pharmacokinetics with any one patient without, just depending on the population data, we have to be very careful. So the alternative is fentanyl and the semi-synthetic opioids, or hydromorphone. And here's an example, it's kind of blurry unfortunately, showing the dosage reduction in morphine based on the GFR, and once the GFR falls under 10, we give about 25% of the normal dose of morphine. With methadone, it's about 50% of the normal dose, but hydromorphone is probably safe to use in the usual dose in children. And now we're getting data on the pharmacokinetics of hydromorphone in children. So in conclusion, I'd like to quote William Osler, who said that if it were not for the great variability amongst individuals, medicine might as well be a science and not an art, because in children with chronic renal disease, we are still practicing an art and must be very careful in assessing these patients before surgery, monitoring the drugs we give carefully, and careful, judicious fluids administration during the surgery. Thank you very much.